A patient managing stable cardiomyopathy on land faces a vastly different physiological reality than a diver descending into a high-pressure aquatic environment. Historically, the simple presence of that diagnosis on a medical chart resulted in an automatic failure for scuba diving clearance. Recent updates to SPUMS and UK DMC guidance have changed that protocol. A strict ban based solely on the name of the condition is no longer the standard. Clearance now depends on a direct comparison between the patient's cardiovascular reserve and the specific hemodynamic loads imposed by the underwater environment. This approach treats the heart as a functional system, requiring clinicians to look at how specific cardiac metrics hold up under external stress. Scuba diving is not a neutral activity. It operates as a severe, multivariable cardiovascular stress test. The first variable in this test is immersion itself, which physically increases venous return. Hydrostatic pressure drastically shifts blood volume from peripheral limbs into the central thoracic cavity. Cold water then triggers severe vasoconstriction, driving up cardiac preload as fluid forces into the heart. Simultaneously, massive resistance vectors drive up afterload, pushing against exiting blood. Add to this the third variable, the mechanical, muscular workload required simply to exercise and propel the body against the density of water. The final compounding variable is an acute spike in sympathetic drive, triggered by both the cold exposure and the baseline psychological stress of the environment. Together, submersion creates a massive, inescapable circulatory load. This sequence tests the absolute limits of a patient's baseline cardiac efficiency. A healthy ventricle adapts. An impaired ventricle responds differently. It lacks the functional reserve to manage sudden, compounded spikes. When that functional reserve is exceeded underwater, the first terminal failure mode is immersion pulmonary edema, or IPO. This diagram shows a struggling heart failing against high afterload vectors. The ventricle's inability to handle the sudden central fluid shift causes fluid to physically back up and pool directly into the pulmonary system. Cardiomyopathy strongly predisposes divers to this life-threatening backup. The second terminal failure mode is incapacitating arrhythmia. The acute sympathetic drive and physical stress of the dive can trigger disorganized electrical rhythms within a structurally compromised heart muscle. On land, an episode of syncope results in a fall. Underwater, syncope resulting from either pulmonary edema or arrhythmia is universally fatal. These exact physiological failure modes dictate the structure of current medical guidelines. The first step for any clinician is to immediately rule out absolute contraindications in patients who lack the necessary physiological reserve. This decision tree starts with cardiomyopathy, branching downward into universally unsuitable phenotypes, active heart failure, and reduced ejection fraction. It expands to strictly rule out hypertrophic and arrhythmogenic structural risks, electrical factors like ventricular tachycardia or implanted ICDs, and any history of immersion pulmonary edema. Removing these high-risk categories reveals the acceptable clinical profile found within the guidelines. A potentially diveable candidate must establish a baseline of being completely asymptomatic, medically stable, and well-treated. Crucially, the only candidates who can be considered for clearance are those possessing a normal or preserved ejection fraction, specifically greater than 50%, to ensure they can counteract the heavy immersion load. Identifying this acceptable candidate requires a specialist cardiology and diving medicine assessment utilizing 7 precise data streams. Point 1 is phenotype identification. The clinician must determine the exact classification of the cardiomyopathy, whether it is dilated, ischemic, or fully recovered. Point 2 is function verification. This requires echocardiogram data populating our clinical dashboard, proving an ejection fraction greater than 50%, alongside normalized chamber dimensions and normal pulmonary pressures. Point 3 is symptom evaluation. The required state here is absolute. 0 indicators of breathlessness, syncope, or exercise intolerance in the patient's daily life. Point 4 is the arrhythmia burden assessment. A clean, stable ECG and Holter monitoring must definitively confirm the absence of ventricular tachycardia or significant atrial fibrillation. Point 5 measures exercise capacity. Cardiopulmonary exercise testing must yield a graph that proves the diver has sufficient functional reserve to handle a submerged emergency, far exceeding the minimum requirements of a calm recreational dive. Point 6 is an analysis of current medications and devices. Clinicians must strictly evaluate the underlying pathological reasons for any prescribed beta blockers, antiarrhythmics, or diuretics. Finally, point 7 establishes overall stability, requiring a documented absence of any recent deterioration or heart failure episodes. This 7-point aggregation provides the data necessary to stratify risk and verify that the patient's cardiac efficiency can withstand the physiological demands of the dive. Clinical assessment for cardiomyopathy divers has moved beyond the presence of a nominal diagnosis. Fitness is determined by the patient's cardiovascular reserve and their ability to tolerate the circulatory changes of immersion. And equally important is the risk of incapacitating arrhythmia low enough for them to independently manage an underwater emergency. Rigid diagnosis-based bands are an outdated approach to sports cardiology. Precise, data-driven physiological risk stratification is now the standard of care for diving medicine. Applying this functional matrix allows clinicians to confidently clear preserved patients for diving, maintaining strict objective barriers to protect those at risk of fatal decompensation.